I'm Cheryl Connors, Executive Director. My pronouns are she, her. And here I am in person. There's a whole body, not just on the screen that we've been for 4 years. We are so incredibly happy to welcome you back in person. And in saying that, we are streaming to our educators at home. So let's everybody applaud and say hello to our educators at home. But we are super happy. Let's just do a little recap of where we were 4 years ago in 2019 in Montreal. And the irony of having Robin Hanley Defoe speak to us about resilience. I'd like to say that I was just brilliant, that somehow I had a crystal ball and knew what we would all be going through. But I'll tell you, that talk and what she said to us, I don't know if anyone here in Montreal? Yeah. And she talked about, her mantra, the words she said to get her through tough times. Robin does hard things. And when just a couple of months later, we were in the midst of this global respiratory pandemic, and my overwhelming concern was, I'm going to keep my members safe. I'm going to do anything I can to get information out to you to keep you safe and keep your patients safe. And I think we did a really good job at that. So, but I will tell you, and there were days when it was like first thing in the morning, late night, but you guys were out in the field. What you were doing was so much more difficult. And some of you got sick. Some of you got sick volunteering in long-term care facilities. And I couldn't have been more proud to be the executive director of this organization and help to lead you through what you did. But throughout it all, what I kept saying to myself is, Cheryl does hard things. And I hope that worked for all of you as well. And to be here back again in person, I can't say, I couldn't be more proud of everyone. What a great community, how we relied on each other and we got through it. How many lives were saved because of the work of the people in this group. We should all be very proud. And I'm going to turn it over to Erin Ladd right now. Erin is the chair of the conference planning committee. And as you can see, we've got a great program and we've really got some interesting topics. I think we're going to have a great 3 days here in beautiful Vancouver. We did order sunny weather for you as well. So enjoy that. And I'll let Erin talk right now.
Thank you so much, Cheryl. First and foremost, welcome back. We made it. We're through on the other side. It's not over, but we are ready to shift gears and to change the outcomes for our patients. First and foremost, I want to thank each and every one of you for coming. Cheryl is the driving force behind the CNRC. She is everything for the CNRC. We spent many nights on the phone with her, expressing her concern for each of you. There were lots of tears that were shed. There were lots of times where she said, I don't know how they're doing it because I can't do it. There were lots of times where she said, we need to get them more information. Can you find it? My response was usually, no, there isn't any. But she was the one that stayed up countless nights worried about each and every one of us. She really is the face of the CNRC, but most importantly, she's the heart of the CNRC. Now, one of the things that Cheryl has done, yes. As the chair of the conference committee, I want to welcome you. And I also want to tell you that Cheryl has put together an amazing conference. She does every year. She is the one that figures out exactly what we need by talking to us. How many times she's been on the phone with you for hours? Anybody knows you get on the phone with Cheryl, plan for 2 hours. But she's put together an amazing program of the things that we really as educators find important. I hope that you have the time and energy and capacity to take in each of the speakers. We have such amazing sponsors who have done so much to take care of us, to help our patients, to help our clients, to help those that we work with. I wanted to thank those sponsors. As we go through our week together, our 4 days together, 3 days, not long enough. The time that we're spending together, take the time to learn from each other, because there's no replacement for that connection that we have together. I want to welcome everybody and once again, thank everybody for coming and being present with us. Thank you again. And I really hope you have a fantastic 3 days.
Thank you, Aaron. I'm going to first, and I should have done this first, but we would like to begin by acknowledging that we are gathered on the traditional, ancestral, and unceded territory of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh. I spelled that out.
That's good.
We recognize the enduring presence and deep connection of these Indigenous nations to this land. As we come together in this space, it is important to reflect on the histories, cultures, and perspectives of the original caretakers of this territory. We express our gratitude for the opportunity to meet, learn, and collaborate on this land. I have the privilege of welcoming our first speaker, Dr. Chris Carlsten, to speak this evening. Dr. Carlsten is one of the world-renowned leaders in studying air quality. He works at UBC at the Air Pollution Exposure Lab, and I'm going to turn it over to him, and we can learn, more about how climate change is impacting lung health. So welcome, Dr. Carlsten.
I think I want this one.
You want that one?
Yeah.
Yeah.
Thank you.
Sounds good.
All right. I have this microphone here so I can wander if I get antsy. But I won't be antsy because you guys are so friendly. The balloons and everything, I feel so at home. Cheryl knows that when she asked me to do this a while ago, I was in the middle of 3 months of never-ending grant submissions, which ended at 10 a.m. this morning. And I'm glad it did because otherwise I wouldn't have made it here. But I'm much more relaxed now. So happy to be here, see some friendly faces and meeting some new people. So I'm going to talk, as you heard, about climate change and lung health. I've thought a lot about actually how to present this and connect with you, and I hope I do that and leave time for questions. I don't know if Sonia's here, but I'm just giving this little anecdote that we're lucky that at VGH, we have an incredible educator. We have multiple, including Carmen and others, but I'm just speaking about Sonia in particular because she's really taught me about how much of an effect that you all can have on patients, and in particular around air quality. And I'll show you more about what I mean specifically in a bit. So I wanted to introduce just briefly the Legacy for Airway Health because it's a program that's been around for about 4 years now. I'm the director, and it's really helped connect with educators, but also the broader community around air quality, but also other topics. And it started with what you see here, just recognizing that asthma and COPD has really unacceptable rates and rates of exacerbation and rates of overall suffering, not only in BC, but of course worldwide. And we wanted to, thanks to a donor and the resources from that donor, make a difference in that regard. And so we started asking really province-wide what people's primary concern was, and of course it varied. And I'm talking about people who have lived experience with asthma and COPD. And I'm going to tell you a little bit about the part of it that I think relates to tonight, which is that a couple of the 9 most concerning items to this broad group of patients with asthma or COPD throughout the province of British Columbia was air quality and something to do to make their lives and the lives of those they care about better in the face of this air quality. And so that's going to really tie into what we talk about. And I'm just making clear that this was from not me or the people I work with every day, but really the whole community that met over months and months and came up with these priorities. And although it's really listed at the top because we put prevention first, because we think that we should try to do what we can to reduce disease. And then, of course, we need to take care of people who have it. It really is foremost in our mind when we think about the overall spectrum of what we can do for our community. So these are the kinds of people that form the Community Stakeholder Committee. It's actually now called the Community Partners Committee. We've changed the word because the word stakeholder is actually no longer favored. But it's the same committee. It fluctuates around 20 people. It meets regularly. And again, it feeds back to us information. And here you can see, although not to see the entire, and you're welcome to get these and look through the whole journey and all of its granularity. But what you see about on the bottom is that whether it's asthma or COPD, one each of these two cartoons, essentially concerns about wildfire came up repeatedly. And again, this was an open-ended forum. It was not us saying anything other than asking questions and then extracting that data. And this is what we heard. Of course, other things, including spirometry. I mean, there's many other projects I could refer to, but for the purposes of today, it was really remarkable to hear how much concern there was about wildfires. We also looked at other healthcare providers. We used a specific community in Williams Lake to try to get an understanding of outside of Metro Vancouver, in other parts of the province, what people were feeling about the support for wildfire smoke concerns. And as you can see here under the green, they really want, including you, really want to help, really want to serve the community, but they don't always know what to do. And even I don't always know what to do. And as you'll see, a lot of the questions about exactly what the right thing to do in the face of wildfires is unknown. We're actually pretty early in the days of understanding the best thing to do. We have general recommendations, as I'll show you, but they're just that, they're very general. They're not really tailored to individuals, and sometimes the evidence for these recommendations is actually quite weak. They may be logical, they may be intuitive, they may be what you would guess would be the best thing, but they're not always evidence-based. So we actually have a long way to go. We also asked the general public, and we asked again throughout the province through a survey, what are people hearing about warning systems for fire smoke? And what we heard is that they were not hearing enough, and they were not hearing enough necessarily in the way that they would like to. For example, things that surprised me, but shouldn't have, I guess, it was just my maybe being a little bit naive to the reality throughout the province, is that there are some communities that get most of their information purely through the radio. And they may not have good internet access. They may not have the kinds of media that I'm used to perhaps in my day-to-day. And so we learned that throughout the province, there are very different pockets of how people prefer communication, in what ways, and that we need to do better, because we have these very fancy warning systems. We have relationships with the big phone companies that can send alerts, et cetera, but they're not always being received, or they're not certainly being received in a way that is actually very helpful to at least some people. So this is the view from my lab, the Air Pollution Exposure Lab that Cheryl mentioned. And what you're seeing is a view from the same window on days very closely spaced in August, as you can see. And so it looks like two different places, but it's actually the exact same view. The mountain is just eliminated by fire smoke in 2018. And of course, we've been worried about fire smoke for some time now. But about the same year, as you can see, there was a report that came out from the Lancet, a major medical journal, and it showed that air pollution was causing 9 million deaths. There are different estimates, some 6, 7, 8, but somewhere in the range of 6 to 9 million deaths per year. And that was in general for air pollution. But what we're most concerned about is that it's just getting worse. And I really try to give these talks and not make them kind of doom and gloom, because there are things we can do, and there is reason to be hopeful. And the only way, regardless of how you feel, that we're going to improve the lives of our patients is to remain hopeful and to remain positive and to get that evidence that we need to do what we can for them. And I know everyone in this room feels similarly about using that evidence for their communities. But nonetheless, it's important to recognize that the quality of the air has actually gotten worse. And this is not just an opinion. This has been documented repeatedly. The average air quality in Canada, including British Columbia, has actually gotten worse in the last 10 years. And that's after decades of huge improvements through the 70s, 80s, 90s, et cetera. But we've really taken a step backwards, unfortunately, because of these fires. So early on in this fire phenomenon, by we, I mean colleagues and teams, of course, looked into the effect this was having on patients. This is a nice graph, I think, because it's pretty easy to follow. I don't have a lot of, I hope not anyway, complex data, because I think it's just hard to present that in a short form, and I want to make some other points tonight. But I do have a few slides with data such as this one. And again, I think it's easy to see if I just walk you through it, that the blue bars are physician visits, and the line, the black line, is particulate matter, which is the, if you look at air pollution in that picture that I showed you, and it looks kind of like a gray blanket. Well, that blanket is really many, many millions of tiny particles on top of each other through the air that you see. And that black line shows that as those particles went up in concentration, the amount of them in a given volume of air, so did the visits to physicians. So it's simple, quote unquote simple, but it's also profound, because it shows that when these events happen, the demand on the system, and of course the suffering that goes with it in the patients, goes up. And from there, there's been much more. That was an early study, kind of a seminal study. From there, there's been much more work, and you can see in a more detailed fashion, for example, these risks in this box. And so this is actually not just about visits to physicians, but it's also about inhalers. So there's multiple levels of cost to the system, but roughly 10% increase in inhaler use for every 10 microgram. Now, don't want to get too technical, but it's important where it says 10 micrograms per cubic meter. So a 10 microgram per cubic meter increase normally is a pretty big deal, but in fire season, it can go up by 200. So 20 times that. So, you know, on a non-fire season, the level of air pollution in a place like Vancouver is 9, 8, 9, maybe 10 on a bad day. If it goes up to 20 in the non-fire season, it's pretty bad, relatively speaking, because normally, like I said, it's 8 to 10. But in the fire season, I don't know if you noticed in the last slide in Alberta, that was 250 micrograms per cubic meter. So 25 times. And then you multiply it across these risks. So these are big effects across the population. And then to put it a different way, you can see this slide. This is kind of almost a bottom line slide. Obviously, not because I'm done, but I want to move on to other issues. But as far as the question of, okay, what is the impact? Well, you can see here, you can just read across on the bottom. There's that Ventolin that we already talked about, all respiratory, which is grouping all those red together. In red, physician visits, but even more recently, we have this mortality is kind of what we call this hard endpoint, which is true, as sobering as it is. But more recently, we've been able to show that the death rate from respiratory conditions is elevated with smoky days, and it's actually more pronounced than cardiovascular endpoints. Now, you're respiratory care, and so am I, but in air pollution in general, cardiovascular endpoints have actually had a bigger burden on the global scope of disease for forever that we've been studying traffic-related air pollution, the typical air pollution that's plagued us for decades. With fire smoke, it seems to be that respiratory outcomes are actually disproportionately greater, and we don't know why. That's some of the research that we're trying to pursue, but it has a huge impact on respiratory endpoints. So, as I said, getting worse. I'm not just going to purely pour on the doom and gloom, but it's important to recognize that the fires are getting bigger. Obviously, this says 2021. In Canada in general, as people probably know, this past summer, it was a bad year overall for the country. BC was oddly relatively spared. We had very little compared to previous years in BC, but obviously the East and then down into the United States, making the Canadian average 2023 the worst that it's been historically. With climate change comes lightning, and it's not such a big deal in the West, but with lightning comes exacerbations of asthma known as thunderstorm asthma. So I'm not sure if people are familiar, but it's so bad in some places. It's not a very common event, but when it occurs, for example, in Australia, which has had the worst of it, it can completely overwhelm the system. There can be problems just getting into emergency departments, et cetera. So it can be a very, very strong phenomenon with the release of pollen spores and other allergens. So this is another view from Vancouver. At this point in time last year, there was a day in which Vancouver's particulate matter was worse than anywhere else in the entire recorded world, which now is pretty much everywhere because almost every community now has an air pollution monitor. So the whole idea of Vancouver as a kind of a haven for clean air certainly is not true year-round anymore. And one of the things that we showed, and I think some of you, this is not a mainstream test perhaps, pheno, but it is used in some centers by including respiratory therapists. We do it in our clinic, and Sonia, who I mentioned, does it. So we showed that with, you can see the increasing level of particles. I should say that it's kind of buried in there, but clean air or filtered air is the standard, and then it's 20 micrograms per cubic meter, 50 and 150, which again is that metric of per cubic meter micrograms that I described before. And the pheno, which is an inflammatory marker generally associated with eosinophils, goes up. And really the point of the slide is that these are now levels that are common in the summer. And here's just another way of looking at it in terms of very recent data. So in part, we have to continue to show that this is not something that happened in the past and is no longer happening now. It's continuing to happen, that we're having more physician visits, et cetera. This slide is, I think, important amongst, I guess, all of the slides. One that I want you to remember in the sense that I've been talking about particulate matter, but I'm going to now get into the rest of what climate change does, because unfortunately, it's not just the fires, but it's a number of other factors that come with climate change. And so that's the heat itself, and I'll touch on that briefly. That's allergens, which I just mentioned, but I'll come back to a bit, and ozone, which is not a huge problem in Vancouver itself because of being close to the ocean. But when you go up the valley to the east, ozone becomes a bigger problem, and it's also a problem in several parts of the country, in Quebec and Ontario. These different factors that I just mentioned have what I call synergies, and that just means that each one of them alone has its own harm, but when they combine, there are biological pathways. I'm going to briefly touch on them, but it's no fun at this time of day to get into the pathways, but I'm just going to show you a little bit about that shortly, that 2 of these and then 3 of these, et cetera, together actually start compounding, and they're not just 1 + 1 = 2, it can be 1 + 1 = 3, so to speak, because of these so-called synergies. And the allergens I'm making a particular point about, because historically all of my work was about particle matter, the kind of traditional pollution that has been the main topic of the air pollution literature for years. And I think now that the pollen is a bigger problem than we thought, in part because it's not just a quality of life issue, and I'll show you a bit about that later. Increases in pollen actually has a mortality signal. So as you'll see shortly, the increases in pollen that we're getting can actually be associated with death. And I'm not saying that to be dramatic, but it's to really point out the gravity of the situation and how hard we need to work to do whatever we can to minimize exposures. And that'll come at the end of the talk. So this is, I think there's actually a slide that says the same thing, but with the actual data, that there can be up to 10% increase in mortality with allergen peaks. So the heat, I said the heat alone, it is climate change. Most of the health effects traditionally have been about what I said, the fires, the allergens, et cetera. But of course, heat itself is problematic. And one thing to just remember is when we talk about the increase in temperature that everyone loves to debate based on models, this graph here shows that the blue, and just look at the line really, the blue is actually the increase in temperature amongst population centers where people are living, as opposed to the increase in temperature kind of out in the middle of nowhere where nowhere is, and that's called population weighted. So the temperature increase is actually worse if you weight it to where people actually live, because it tends to be that in cities, it's more of a problem because of all of the asphalt and buildings and whatnot that retains heat, the so-called urban heat island. And so unfortunately, where people live is where the temperature change is most pronounced. And there was this event that you may recall a couple of years ago, where over the course of a couple of years, a couple of weeks, about 1,000 British Columbians died. And I'm mentioning this, although it turns out that the deaths were largely not respiratory. They were because of dehydration with kidney failure and cardiac problems. So in the heat arena, although there certainly are respiratory related complications, it's mostly other. And it's really, as this data shows, it's a problem of inequity, because those with mental health issues, with housing issues, with resource access issues were really just vastly disproportionately those who died in this event. So I thought I could not mention such an important thing that happened a couple of years ago, although it's not primarily a respiratory problem. I will come back to air conditioning though, which is something I think all of you can be aware of and can make a difference on in a way I'll describe. This one I probably needn't include because it's a little technical, but the point is really that as you go to the right, 2100 predicting into the future, this model shows that the deaths from the overall deaths from particulate matter are going to be more and more due to fires. So the red is the fire-related particulate matter, and as you can see, the good news, so I said maybe it's not all bad. The good news is that death related to particulate matter is actually is predicted anyway to decrease over time. But of those deaths, the ones that are due to fires is going to be a greater proportion, so that you can see, at least according to this prediction, by the end of the century, 2/3 or so of particle related deaths are going to be due to fires. The point being that we really need to focus on fires and how we can protect people from fires specifically. And as I was telling people in the reception, we can't just assume that what we've done with traffic-related pollution is going to work for fires, because it's not the same. Ozone is going to increase. This slide is starting to get, well, it's not outdated in the sense that it's a prediction, but it's not ideal for this audience because it's mostly, as you can see, the US, but you can also see that in the Vancouver area, that's a nice hotspot, unfortunately, for ozone, which I mentioned before, but the point is another case where the model is for it to just increase, because ozone is largely driven by heat, or it's significantly driven by heat. And that, unfortunately, again, has a significant toll in terms of death. It's been shown most pronounced in Europe, but it's been shown elsewhere. And so, sorry, but another piece of the puzzle that's going in the wrong direction. This is that data I referred to with pollen, so I don't need to reiterate it, but these are the numbers in case you like data, but again, about 10%. And this is this kind of nasty slide that I referred to, just the one real kind of detailed thing from my lab. The point being that when you add allergen and diesel exhaust, but now moving forward, we're looking at the same relationship between allergen and fire smoke. All of these different studies, which we obviously need not look at, are showing that the two of those together gives a much more robust inflammatory signal Whether, these are not things that you're totally unfamiliar with, eosinophils, obviously, et cetera, but we look at the granular detail of all of these pathways. And unfortunately, all the way from the very beginning to the eosinophils, and as you can see, the asthma exacerbations that you're familiar with, drop in FEV1, very clinically relevant endpoints. The combination of allergens and particles, which again are going up with climate change, just makes things much worse, unfortunately. And it makes things much harder for urban planners and all of those who are, again, trying to do something. One of the probably best interventions we can do for the health crisis we face is greenness, is promote greenness and spread greenness in our urban planning. And that literally means green plants, etc. The big caveat being that along with the plants comes allergens. And so I've already told you that can be a problem, but it just shows you how difficult it is to get your head around what is the right thing to do. But thankfully, people are stubborn in a good way in the scientific and policy and urban planning community. And one of the things to do is figure out, well, what allergens are the least problematic, and can we bring in plants and trees that have pollen that is less inflammatory. So this is what I was referring to about what you can do. There's a couple things that the government, at least in BC, I'm not as familiar with other provinces, has done to take a little bit of the sting off the cost of some of these proven interventions. As you can see highlighted here, and well, I should say, how many people here know about this, at least in BC, if you're from BC, tax benefit to, and the specifics are that for the ear filter, you need to have severe respiratory condition, specifically asthma or COPD. It's a little frustrating that they confine it to those two, although that's a big chunk of it. But if you had interstitial lung disease or something else, unfortunately, the way it's defined, if you read it in all the granular detail, it doesn't cover probably as many people as it should. But anyway, how many people have heard about this? Couple, like, but I mean, not that many, right? And well, of course not, I don't know what percentage is from BC, but even if 20-something% of the people here are from BC, it would be, a minority of those. And so I talked to 2 people about this in clinic today. You never know what's going to happen because it's a little bit of a pain. You have to buy the thing. Well, first you have to get a prescription, and then you have to go buy it, and then you have to wait till tax season, and then you have to do the accounting. And so it puts a bit of a burden on the individual, which I wish weren't the case, but at least you do have these options, and it's a step. What I want to do, I should say as a team, we recently published this paper, which is one step to persuade the government that they should, and again, BC, I suppose I'll keep it here because that's where the data is from, support these, and this is the example of the air filter, the air conditioner is a separate analysis, but actually support the financial burden of the air filter, not just for people with asthma and COPD, not just for those that are severe, but really all citizens, because if you just take all comers, and here's the data, hopefully, again, I'm not making things too complicated, you can understand easily what 4,500 severe exacerbations means, and 531 emergency department visits. But the graph really shows, you probably can't see it on the bottom, the colors refer to how much money spent to gain a quality adjusted life year. And a quality adjusted life year, QALY, is a standard metric in health economics, the study of how much things cost in the health environment and the pros and cons or benefits and risks of a given intervention. And it shows that depending on the health region, so the province is divided into health regions, you can see them kind of like a jigsaw puzzle. Depending on the health region, all of them fall under $100,000 per quality adjusted life year. It sounds like a mouthful, but what I can tell you is that under 100,000 Canadian dollars for a quality adjusted life year is considered worth it in general health economics. So It's more beneficial in that blue region. It's less beneficial in the red, but they're all under 100,000. And so by standard health economics, this is the same kind of algorithm that's applied to drugs. If this was a drug, it would be approved. Generally speaking, obviously, it's more complicated than that. But in general, if this were a drug and these kind of data, it would be approved. But for some reason, because it's not a drug and it's a filter, it's somehow too confusing to get through the bureaucracy. And so we're working on that. There are other resources, of course. I'm going to come to the websites for these later. And although it'll just be on the screen, I'm happy. I can just tell Cheryl right now, you're welcome to share these slides so that the websites are available to anyone. But BC, as have other provinces, but I'm not as familiar with the others. BC, I can state with confidence, these are from the CDC, has developed really helpful tools. But again, the problem being, and you'll notice on the bottom left, it looks a little bit like an action plan, and I'm going to come to actual the action plans in more detail. But as with action plans, as with any action plan, it's a little problematic to put people in these boxes because not everyone is going to respond. Not every asthmatic is going to respond the same at a given level of pollution. So as I was saying before, I think we need to move, and you'll see the examples that we're trying to promote, to a much more personalized approach to action plans for the climate specifically. And that's this. And this is 100%, well, I shouldn't say 100%. This is led by Emily Brigham, but there is a team, but it's really her inspiration. Emily Brigham's one of my colleagues who came from the US a couple of years ago. And to her credit, moving from Baltimore, which is not terribly affected by fires, she very quickly picked up on the fire problem we had and said, well, you know, we have action plans in general, but we don't really have action plans for these very most problematic exposures that are happening here in BC, including fire and heat. And so, again, not going to go through this whole thing, but basically this page, there's essentially two sides. This page is really about kind of preparing the individual, going through what do you have in the house, what are the resources. You can go through the whole list, understanding what the effect of closing the windows are, and very sort of bread and butter, for lack of a better word, things you can do to decrease your exposure. And then there are QR codes, as you can see, so you can learn much more because, of course, you can only print so much on a piece of paper. But here, this is what I was referring to in the last slide. It's very reminiscent of traditional action plans, except for here, it's what to do at a certain level of air pollution. And instead of telling you, it's blank because you work that out with your provider because different people know from their experience. Well, hey, like last summer, I was in that level of air pollution all summer long and it didn't bother me one bit. Why am I going to lock myself up at that level of air pollution when for the last summer, and also, by the way, the summer before that, I was fine and I really need to go pick up my kids at school. Whereas somebody else, you know, at an even lower level of air pollution was hacking and coughing and coming into the emergency room. And so getting that experience and tailoring it to the individual, we think is really important. And doing that in partnership with people like you, who I know from experience, again, understand how important this is and are passionate about taking the time to talk about it. So I put Emily's email here because part of my being here, and maybe the most meaningful part, is I really want this to be productive and not just kind of a lecture. You know, the pictures of the fires, we've seen those in the paper. But what could really make a difference is if you can work with Emily and her team to try to make those materials better. The one I just showed you in the last couple of slides, that's actually literally like the 10th or 11th, and Carmen and others have helped out, edition of this. And Emily, to her credit, is very eager to continue to improve these and make it more meaningful. I'm almost done, by the way, but no one started the timer, so it says I have 30 minutes left. So I'm just telling you, that's what I see. Yeah, but this really is the last bit. I mentioned at the beginning about these grants. So this is the last of 3 major grants. And this is literally what we submitted this morning in terms of the figure 1, the first figure on page 1 of this grant. And what we're trying to do is not only understand the effects of wildfire smoke, but most importantly, what communities and what groups and individuals are most susceptible, vulnerable, or at risk, and really understanding the community values, what's most important. This is a whole social science, and this is a team grant, so this is not my area, but we have social scientists that are expert at going to communities and trying to understand what is actually important to you and how can we help get you the information that's important to you, not just what information we feel is important to us as scientists that we put in some nice paper that may not mean anything or trickle down to you. So the middle of the circle is really more biological understanding, but the next circle out is understanding these risk factors of age, et cetera, diet, et cetera, community, neighborhood design, and things that I mentioned earlier in terms of trees, et cetera. And really taking the values of the community and making sure that the output on the bottom is optimized in a way that is understandable and helpful to those communities. So that's a grant we put in this morning. When I was doing this, I also thought, oh man, I would have been much smarter to have included this group in this bottom and it doesn't matter, it's submitted, so you can join on even though you're not in there. But these are the groups that are going to be on a working group. These are the I should say, the entities, the institutions and nonprofits, et cetera, that are going to be on a working group that are going to come together to do just what I said, to say, like, this is what our community, and your community is different from BC Lung Foundation and the BC Cancer Foundation, et cetera, all these that you see here. These are what our community are telling us is important to them, and we need your help to translate your science in a way that I can bring back to my community, including First Nations, the Carrier-Sakani First Nation group of nations really is a partner with us. So I won't go through the rest of this slide, but that's a huge part of this grant and what we think is going to make it special, I hope, in this competition. We'll find out in April. This is just another way to look at the working group, meaning that it's got national level, provincial level, patient partners, and an Indigenous group that is really critical to the effort. So this is my last slide. Hopefully I wasn't too far off. These are the websites, as I said, easier to just get them either from me, email me, or like I said, Cheryl's welcome to distribute this. And this I have to admit, this is for typically another clinical audience, but I don't think you guys actually fill out death certificates as far as I know. But oftentimes when I talk to physicians, I raise this question and I really don't know the answer. Well, I know the answer that I've never done it, but I don't know the answer of what's right in terms of in a given individual's case, whether we can confidently say that that particular death was due to air pollution. But I do know that if you look at the epidemiology, meaning the population level data, as I showed you earlier, deaths are occurring. If it occurs in one exact case is very, very difficult to determine, but they are occurring. And so with all of you, I hope that we can partner, as I said, and try to make a difference. And there is cause for optimism because these air conditioners, these air filters, they do work. And we just got to get them to the people that need them. So thank you, and I'm happy to take any questions. Cheryl promised me there'd be a lot of enthusiasm.
I said you asked questions, but I have one. Sorry, let me go to the mic.
Yeah, that should be still good.
So air quality is something that I've been passionate about for a long time. Why can we not get policymakers to care about air quality?
Okay, well, I mean, for one thing, there's always, all day, every day, most of the time anyway, I'm thinking about air quality. So to me, it's such a big issue. But I remember profoundly, and we've talked a little bit about the impact of COVID on your group. When COVID happened, well, first of all, it was vaping. I was actually working on vaping in 2019 into 2020 when COVID started. And so suddenly everyone forgot about vaping. suddenly everyone forgot about air quality. And so there's the reality that there's the sort of hot issue of the time, and obviously COVID's not insignificant. So there's a lot of other constituencies. There's an overdose crisis in BC. The people who work on opiate overdoses have their statistics that they cite as how important that is, and it is important. So there's competing priorities. The other issue, I think, is that in general, pollution is something that takes years to develop and takes years or decades to get rid of, and that's the pollution itself, and it's also the disease. And so sadly, and it's not a Canadian thing, it's all around the world, politicians are thinking in 3-4 year cycles. And so they know that there's not a whole lot we can do about pollution in the next 3 years. And so what are they going to do to make a difference that is going to be tangible, that they can point to and get elected on? I mean, that's a little bit cynical, but I think it's pretty, basic, well understood dynamics of politics. But again, the optimistic thing is that my observation, it's more from the vaping and smoking, is that when a politician is personally affected by something, that's when things happen. And so I'm sure you know this from experience. You really got to find someone and connect with someone on a personal basis. And this is what happened with John Horgan, is that I think it's common knowledge he had cancer, probably related to smoking, and then a whole lot of smoking related money got put into various initiatives, and that's great because smoking is a problem. So that's a few different pieces of, I guess, the answer.
We have a question. Andrea.
Yeah, thank you so much. There's so much that you talked about that I really appreciate. I appreciated the greening of the cities. I think every building should have some kind of something growing on it if it doesn't have solar panels. Like, what are we doing? I love that idea. I also really appreciated the action plan and tailing it to the individual. As educators here, you're singing our song. So thank you for that. I do have a question. You talked about air filters, and you were really focusing on the air pollution and the smoke. And I'm wondering if you have linked it to infectious diseases and using air filters to reduce infectious diseases, as well as the smoke, and would that help improve the uptake, or would that help sell it? I'm just really impressed that BC has done that, first of all, but yeah.
That's a great question. So it wasn't until, I shouldn't say it was just with COVID where that question started to become a big one, but it certainly got taken up a huge notch in terms of what these filters can do for infectious disease. Of course, like to give you a simple answer, but it's not so simple. It really depends on the size of the organism. But they certainly help. And so yes, the bottom line answer is that they do help with viruses and bacteria to a certain extent. The big caveat is that most of them are marketed to add ozone. And good, I'm glad you're shaking your head. And all the questions you asked and all the comments you made were right on. So it actually makes me gratified that I clearly you were listening. But thank you for, it was not to be assumed. Thank you for shaking your head because you clearly recognize, and presumably most of you do, that the ozonizing air filters are probably more harm than good because of the ozone inflammatory effect on the airways. The good thing is normally you can just turn that button off. It's not mandatory. But the filters alone, even without the ozone, do help. So I just recommend don't either buying one with ozone or just turning it off. And then you're doing something in the right direction.
So it sounds like what you're saying to me is that they aren't mandated to be a specific kind of air filtration.
Well, it's HEPA, right? So HEPA has to be, I mean,
yep.
You're right. No,
Good.
you're right, because I said air filter, which is a very vague thing. I mean, like this is a very coarse filter between my fingers. But when I said air filter, I should have said a HEPA filter.
Okay.
And a HEPA filter, if it's actually doing, I guess there can be some fraud out there, but if it's doing what if it's meeting the regulation that it's supposed to meet, it's going to eliminate over 99% of particles down to a micron of size, which is, and that's why I got into this when I made this comment about, oh, it depends on the bug. When you start talking about a micron, then some bugs are smaller, some bugs are bigger. And so it's not ideal, but it's 99% of those size.
Thank you very much for sharing your information. I appreciate it.
Thank you.
Thank you very much, Dr. Carlson. I really appreciate, we all appreciate you coming here and taking the time and that we can learn about air quality. And Aaron's going to come up and introduce our